Hello, everyone. Thank you for joining this morning. I am not sure if you've had a chance to read through the programme book, but I'll give a brief introduction. My name's Dr. Zara Toney. I am currently a foundation trainee at the Bristol Heart Institute in the UK. I conducted this research a couple of years ago now. With COVID and everything, things have been delayed, but this was a project that was a systematic review done in a group of other undergraduate doctors and led by a professor in obstetrics and gynecology. So the talk itself is just an overview of what that research entailed and our main findings. And it covers migraine incidence and management in obstetrics and gynecology. So as I said, it was a systematic review conducted in 2019 in Nicosia in Cyprus. And it looks at the incidence, symptoms and treatment options and the complications for migraine sufferers in the obstetric and gynecology world. We looked at exploring the use of migraines as a marker for antenatal care and for conception prescription. So this is the journal that you can find the paper in if you did want to have a further read as well. And I've included a link that you can copy down to. So I thought I'd start with a little case presentation, seeing as we're all clinicians and scientists here, and this might get our morning juices flowing. So a 24-year-old female presents with a unilateral pounding headache. She was found in tears on a park bench by a passerby, who initially the patient mentioned that her vision went funny and could see lights dancing around and black spots. A friend at work, where she was before she managed to migrate to a park bench to try and find some medication, a friend at work mentioned her speech was slurred. Hello?
Excuse Dr. Zara. I think your slides are not moving. I can see you only first screen, first slide.
Ah, okay. Let's see what's going on here then. Let me know when it changes.
It's fine now.
Okay, perfect. I'll leave it like this then. Yeah, so this was just the slide with the journal that you can find the paper in. And this is the start of the case presentation I mentioned. So I just got to hear a friend at work mentioned her speech was slurred and the patient reported severe nausea, phonophobia and photophobia. So she couldn't look at bright light. She couldn't listen to any loud sound. She was working in a very loud office. On further probing, she mentioned that she had heavy but regular periods and reported getting headaches around the time of menses. So on examination, her observations were stable. She had a national early warning score of 1. Her heart rate was 107, so a bit tachycardic, which is a normal pain response. Following a neurological examination of the upper and lower limbs, power was 5 out of 5. Her cranial nerves were intact and her BMI was 26. So a further systems review, no abnormalities were detected. So that patient in question was actually myself. I am a migraine sufferer, so I have a personal vested interest in this research that we did. And that was a case of myself where I hadn't had migraines for about 10 years. They started upon menarche when I was a teenager and hadn't had them for 10 years. And then all out of the blue, they came back like this. So I thought I'd share that. So migraines are the most common type of headache, the third most prevalent disorder worldwide, 7th highest cause of disability worldwide, and women are most susceptible during their reproductive years. The rates increase from 4% to 25% from the onset of menarche, so when their periods start, and decline post-menopause. So a brief definition, etiology, pathophysiology of migraines. Migraines are a primary headache disorder, and they're characterized by recurrent headaches, and they're moderate to severe, so quite debilitating. They typically affect one side of the head, so a unilateral presentation, and they're pulsating in nature, feel like a stabbing pain, and last from a few hours to 3 days that someone can be out with one. You sometimes can have a prodrome, so the scintillating scotomas, they're called, that image where I showed the lights dancing around, so people know that they're coming and can get to a safe place, let's say, because if they're at work, they need to drive somewhere. So they have a bit of a warning that someone's coming on. And that's really important for some medications that you can give, such as triptans, sumatriptan, novatriptan, So yeah, those medications you give at the onset of those prodromal symptoms. So other symptoms include nausea, vomiting, sensitivity to light, sound, or smell that we mentioned. And etiology, it's one of those conditions where there's a bit of everything involved. So genetics, some genes have been shown to be more widely linked to individuals that suffer with migraines, and certain triggers such as physiological, menarche, like we discussed, uh, having a period, so menses, and pregnancy as well can trigger it in the first trimester. Dietary, some people report cheese, chocolate, things like that wine can trigger migraines. And environmental, moving from an area of warm air to cold air, so going outside. So pathophysiology is described as largely a neurological disorder, so increased excitability of the cerebral cortex and an abnormal control of pain neurons in the trigeminal nucleus of the brainstem. Some believe that it's a neurovascular disorder, and others believe that it's both combined, neurological and neurovascular. I think there's more evidence to support the neurological side of the argument, because a lot of, I think, third line preventative prophylactic migraine management includes anti-epileptics. So if it weren't a neurological disorder, it's argued that they wouldn't have an effect. So it's not just a condition for neurologists to be aware of. Patients in the UK present first to their general practitioner, so their primary care provider needs to be aware of management of these conditions. And there's quite a few significant differential diagnoses that are important to rule out. So subarachnoid hemorrhage that can have a sudden onset, baseball bat type feeling to the head. And that's sometimes how severe a migraine can present as well. Meningitis is an important one to rule out too. So it's difficult for clinicians when a patient has a history of migraines and then it's confounded by the potential of these other differential diagnoses. So it's important to be confident managing these patients. So further on in the paper, we describe menstrual migraines by their proper term, which is catamenial migraines. So these are ones that are associated with menses, and the onset of menses, the couple of days before their period and the day of, and then a couple of days after as well. So that's due to the estrogen drop and different hormones during that time. So safe administration and monitoring of oral contraceptives for migraineurs is important for clinicians, and the cardiovascular risks and complications for migraineurs and their fetus during pregnancy. So there's contraindications and absolute contraindications in medicine. Catamenial migraines, they're a headache disorder related to the estrogen level fluctuation during menstrual migraines, the menstrual cycle, as I mentioned. Attacks regularly occur for at least 2 to 3 consecutive menstrual cycles between the 2 days prior and 3 days after initiation of menses. So an estrogen withdrawal migraine is specifically encountered in women that take estrogen-based contraceptives for at least 3 weeks and experience migraine attacks within 5 days of ceasing the medication. So some contraceptives, you have a week where you don't take any of that pill, and on stopping that tablet, that's when patients can suffer from these estrogen withdrawal migraines. Prevention of catamenial migraine attacks have been attempted to be prescribed by prescribing oral contraceptive pills. They've tried to prevent these migraines from happening through the contraceptive pills, but then there's this risk of cerebrovascular thrombosis that's been of great concern in the field. So I don't think that's practiced as much in the modern day. And the combined oral contraceptive pill is contraindicated in women with migraines. Exogenous estrogens increase your hypercoagulability state and vascular contractility. So your vessels shrink and you're more prone to clots. So this predisposes women to higher risks of developing thromboembolic events. So strokes and PEs, DVTs, there's a number of studies that have looked at that. So for patients suffering with migraines and they've been diagnosed with SLE, hypertension, previous TIAs or strokes, full-blown strokes, ischemic or hemorrhagic, and smoking as well, there's an absolute contraindication to using the combined oral contraceptive pill. So for our study, we used the PRISMA framework in order to design it and conduct the systematic review. So I just thought I'd include our search criteria here and how we selected particular studies and weaned out ones that we didn't want to use. And these were based on the following exclusion criteria that's detailed here. So we went from an initial search, as you can see here, from a result pool of 1,690 studies down to 38, which met our criteria. So the main take-home message here that we found with looking at these studies was that you need to manage patients based on their contraceptive goals and status. There's no point giving a patient that's considering starting a family in the next 6 months to even a year with treating them with progesterone contraception, such as the either progesterone only pill or the injected progesterone, the depot injection, because that takes a number of months to fully come out of someone's system. So you start by including the history, and if the patient suffers from headaches, define the type of headaches. As I said, there's other common differential diagnoses, including cluster headaches, which have their complete own different management schema. So you establish the diagnosis of migraines. Is the woman within her reproductive years, or is she already taking contraception or interested in contraception? Is she interested in trying to get pregnant? And then you would look at preconception counseling and go with medication that's widely accepted as being safe in pregnancy. So paracetamol is the safest medication that we have in medicine for patients that suffer any type of pain during pregnancy. However, there are some risks associated with using paracetamol for more than 28 days for the fetus. And sumatriptan, there's an increase in congenital malformations with using it, but it's risk versus benefit in this case, and how large the risk is as well. So if a patient is infertile or not looking at starting a family, then you can go down the fovatriptan, desestrogel route and continuous use of contraceptive. So, as I said, we looked at different groups of migraineurs. So those in the gynecological box, those in obstetric, and those trying to get pregnant or are pregnant. And we looked at complications in pregnancy. So just to go back a little bit from the data we found by looking at these 38 studies, the incidence of migraines in the gynecological group were 11 to 12%, obstetric 9 to 38%, and contraceptive 16 to 54%. The prevalence of migraines in the general female population is 12%. Pregnant patients with migraines is further subdivided into migraine with aura, chronic migraines, and status migrainosus, which unfortunately, as the name suggests, is a bit like status epilepticus. It's a state of constant migraine, and you very rarely get breaks in the time where you're not experiencing pain. So it's quite a sad situation to be in. So 40% of women with placental abruption have a previous history or current history of migraines versus 29.6% in the control group. During pregnancy, 25% of patients had no change, and including those, 80% had not reported migraines in their third trimester, and less than 3% of patients had de novo migraines. Breastfeeding, interestingly, delayed the onset of migraines in the postpartum period, which further supports the notion that it's linked with hormonal changes and hormonal drops. So contraceptives and migraine use. Migraine in the first COCP cycle, you have a 1 in 3 chance of experiencing it in the second cycle of using a combined oral contraceptive. And then again, If you're experiencing it in the second cycle, you've got a 1 in 10 chance for having it in the third cycle. So interestingly, prolonged use of the combined oral contraceptive pill causes a migraine drop in prevalence. So the longer you use the combined oral contraceptive pill, the less chance you have of getting migraines further on. The prevalence of migraine overall in these pill users is 37.7%. So the European Headache Federation, they suggest and advocate that the combined oral contraceptive pill, the use of it is contraindicated in all women with migraine due to the risk of increased stroke. So there's a 6-fold increase risk of stroke. And so it's higher for women that have migraine with aura. So there's migraine and there's migraine with aura, and aura is all those lights bobbing around that we mentioned. So additionally, management of headaches related to the combined oral contraceptive pill, switching from the combined pill to the progesterone-only pill or extending the cycle with supplementary estrogens is the better way to manage headaches that are linked with the combined pill. So I noticed that I've only got 3 minutes left, so I'm going to race through these last little bits that are really quite interesting. Pregnancy complications. You've got a higher risk of a low birth weight baby if you suffer from migraines. You've got an even higher risk of having a baby that's small for gestational age on scans and examination. So this is before the baby comes out. And a slight increased risk of having a cesarean section, a higher increased risk of preeclampsia, which is quite stark as well, and a higher risk of gestational hypertension. So the management of migraines in pregnancy. So this is what I was mentioning about paracetamol even having a risk if you use it for more than 28 days. Poorer gross motor development in children by the time they're 3 years old, which is quite unfortunate. But the saving grace is that the risk is even smaller if you use it for 1 to 27 days. So pregnant women do have something they can use to get through this time. Triptan therapy, notably sumatriptan, was not associated with an overall increased risk of negative outcomes on the fetus, such as congenital malformations. So 3% risk in pregnant women who took triptans and 2.9% in the control. So the risk is almost negligible, specifically with sumatriptan. I think you have to be a bit more careful with other triptans that weren't looked at further. So in conclusion, from conducting this systematic review, we found that there is a lack of prospective randomized control studies and well-designed trials this is likely due to the ethical difficulties in randomizing patients, specifically pregnant patients. No one wants to submit for a study. It's largely retrospective analyses that are done and things like that, looking at records. There's limited information surrounding menstrual migraines and their treatment, small patient populations, loss of multiple participants due to miscarriage or decision to abort. The prolonged use of combined oral contraceptive pills is linked with a reduction in migraine intensity, and pregnant migraineurs have a higher risk of preterm birth, cesarean section, preeclampsia, gestational hypertension, and low birth weight, as well as placental abruption. Evidence is limited, so women with migraines need to be monitored closely. I'd just like to thank the other individuals that were involved in this paper, and all my references can be found on this link as well. Thank you.